Okay. So today, what I wanted to go over for you guys is some SOAP note stuff. SOAP notes is a difficult concept, um, and it's one of those things that you slowly build over time and get better and better at. But I just wanted to give you guys some tips for success. So the HPI, right? So this is probably a review. You can either use your old Hartz mnemonic. Some people use OPQRST. Doesn't really matter. You just want to make sure you get those components. Now, remember that those components are not always valid to a certain complaint, right? Like, so, you know, onset, location, duration, character, all those kind of things. You want to use them when they're applicable, but if it's not applicable, then just move on to the next part of that HPI. Remember, if you use quotes, okay, if you're quoting a patient, it better be exactly what the patient is saying. I shouldn't see his or her in a quote. It should be directly what the patient says. A lot of times I use quotes if somebody uses like poor grammar to explain their complaint, or if they explain their complaint in sort of a vague manner that I normally might not put for my own verbiage, but I'm quoting the patient, and so it's clear that that information is coming from the patient. So the HPI, in the HPI, you need to explain to me what type of patient this is. Is this a healthy 23-year-old female with no medical problems who does not take any medication? Or is this a sick 23-year-old patient who just went under 3 rounds of chemotherapy and is getting ready for the 4th and comes up with this cough, okay? You need to paint the picture of exactly who you're dealing with, because different patients require a different level of medical decision making and a different level of understanding, and it tells the reader what type of patient you're dealing with. Okay, so that's pretty much the HPI. I think the HPI is definitely very straightforward. It gets a little more complicated when you're dealing with special patient populations like a pregnant female or an OB chart. Then there's different components, and that varies from case to case. When we're talking about a review of systems, I would probably argue that in emergency medicine, particularly, the review of systems is probably the most important part of the note. In this part, you need to be ruling out bad and uglies. So it's a focused review of systems. Now, the way that the review of systems works particularly in emergency medicine is like, say that you come in, you have a young female who recently started birth control, and she's complaining of shortness of breath, right? So right there, you're concerned about what? DVT, PE, right? So you need to rule that out in your review of systems. So say that she really is just having an asthma exacerbation, or the smoke from local wildfires is giving her problems. In that case, in your review of systems, you need to rule out the bad and the uglies, which would be a PE, right? That's going to kill her the fastest, the deadest, and the quickest, okay? So that review of systems would appear like this, patient denies any recent immobility, recent surgery, redness or swelling in her calves, pain in her calves, hemoptysis, abdominal pain, nausea, vomiting, diarrhea. Okay, so we kind of cover our bases with some of that stuff, but we're definitely ruling out PE. So even though traditionally we're thinking of putting our differentials down the line, as a really intuitive, smart, good clinician, you need to put your review of systems. Your review of systems needs to follow the differentials that you have in your head. So you should be thinking of the patient kind of at this distilled point, right? I had some attending ER physicians that would say, oh, well, it's an old person with an acute headache, so it's got to be an aneurysm. And if it's not, you need to tell me why, right? So kind of distill into like age, risk factors, and chief complaint, and then use that review of systems to rule out things that are in your differential. Even if you know it's not, you need to articulate that in your chart. Okay, and then obviously physical exam. It's pretty straightforward. I really encourage you to download this SoapNote Basics. It's on the Heritage website. It's got basically all the information that I'm talking about today, and then it's got these great templates, which definitely in year 2 you will use a lot. And then medical decision making. So medical decision making is probably one of these topics that a lot of people don't understand that much, particularly students. But what medical decision making does is it basically formulates your thinking and puts it in the chart so that other people can kind of understand where you're coming from. So I've got in this template, there's a medical decision making kind of the components for medical decision making, which are right there. But basically in this, it's got that you reviewed the history of the patient, that you reviewed their diagnostics, what you think is going on, that you've reviewed their vital signs, what's their oxygen saturation on room air, what are your 3 top differentials. And just as a side note, if you put those differentials in, you also need to make sure that you've evaluated those in that visit. So don't put differentials in here that you're not ruling out, because you just boxed yourself in. There's a good lawyer will say, well, you were thinking it might be PE, so why wouldn't you just go ahead and do a spiral CT or a CT scan on this patient? Well, don't put yourself in that box. If you're going to put it on your MDM, then make sure you've at least evaluated it, and then further in your MDM, you can say why you don't think it is those things. And that's more likely to support you should something go to litigation. A repeat exam is always good for an emergency room patient, particularly if they have abdominal pain, right? So initially you see them, they've got a rigid abdomen, later you've treated, and then you go back in and evaluate, and now their abdomen's soft, non-tender. So that's always great information prior to discharging a patient, like, oh, I made them better, I fixed them, now they can go. So stuff like that, how they respond to medications, kind of under that same category. Did you decide to admit them? Did you consult with anybody? Based on your physical exam, what do you think is going on? Based on the diagnostics, what do you think is going on? That you educated the patient as to the etiology and diagnosis and the risks, and then return precautions too. So MDM, indirectly, it's how you increase your revenue, but really directly, it is how you CYA. So you really need to kind of cover yourself with good MDM. One last thing that I wanted to talk about is the assessment and plan. So there's a good mnemonic for assessment and plan that is do everything that feels right. And that's, so what you're going to do is you're going to give your diagnoses and your differentials. You're going to educate. You're going to talk about how you educated. You're going to talk about what treatment interventions you either did or are doing. You're going to talk about follow-up, and then any referrals. So do, diagnosis, everything, educate, that, treatment, feels, follow-up, and right is referrals. So that's kind of the gist of the assessment and plan. And then there was last thing that I wanted to talk about was the EKG. So if you do an EKG on a patient, there's certain criteria that you need to document. So you should always document kind of like your, like you would dissect any EKG. So rate, rhythm, axis, hypertrophy, and acute ischemia. So the way my little spiel is, patient has a rate of 92 beats per minute. It is of a sinus origin. There is no axis deviation, signs of hypertrophy, or signs of acute cardiac ischemia. Or it could be, the patient has a rate of 50. It is of a, junctional rhythm. So anyway, but you should hit on those key components. So it's rate, rhythm, axis, hypertrophy, and ischemia. if you mark all those boxes, then you get your reimbursement, and everybody else who reads your note is happy, and you kind of check that box. So anyway, I hope that's helpful for you. Make sure that you download this. This is what I'm looking for when I grade your SOAP notes. Everybody's doing really good on SOAP notes. Keep the format simple. I sent out some examples of a SOAP note format. It doesn't have to be exactly like that, but that's kind of what I like, and what I have seen over the years in different clinicians' charts. So just a Word document is fine, and then each section there. So hope you're all doing well, and I would look forward to seeing y'all in person sometime.